All right, we're recording. Hey, welcome everyone tonight. And my name's Darren. I'm the Director of the Lifestyle Medicine and Health Research Centre here at Avondale University College. And we would like to welcome everyone to this session, which I'll give you a bit of the backstory in just a moment, but it's a real privilege to have our special guest with us today. And so for those who are tuning in now, fantastic. And for those who will be listening online, you're also very welcome too. I'm going to hand it over this presentation is actually part of a unit here in our postgraduate course in lifestyle medicine called Lifestyle Medicine for Specific Populations. And that's the lecturer, facilitator for this unit is Dr. Paul Rankin. And I'll hand it over to him in just a moment to introduce our speaker. But let me just say a couple of things. First of all, before he does introduce Professor Esther Chang to us, let me just say that Esther is actually not just a dear friend of mine, but she's been a real mentor to me in the past, and so it's a real delight to have her here today. Only a couple of hours ago, actually, we discovered that Esther's actually been suffering bronchitis quite badly, and she might make a couple of comments about that in just a moment. And so I was texting back and forwards and asking her daughter if, we can call this off, and she's like, no, the show must go on. And so that just says a whole lot about the competency and the caring of Esther. So it's a real delight to have her with us tonight. I've been really looking forward to this. But I'll hand over to Paul, and then he'll introduce and tell you a little bit more about Esther.
Thank you very much. I'm really excited to have Esther here because our topic is about lifestyle medicine for specific populations, and I wanted to touch on the aged care. And the person that I knew that had more knowledge and experience in that area than anyone else was Professor Esther Chang. And if you have a look at her bio on the University of Western Sydney, it's very extensive. But Esther's probably most famous work was the fact that she was an external supervisor for my PhD. And we actually had a really good time working for that. And Esther continually said to me when we were working on that, Paul, tell the story. And I've never forgotten that. Thank you very much, Esther. But I'm going to hand over now to Esther, and thank you very much for your presentation tonight, Esther.
Well, thank you, Paul, and thank you, Darren. It's a privilege to be able to talk to your students. Regardless of me not being well, I think the most wonderful part is that we've got Zoom, and therefore, at least I can say to you, I would not be able to infect anybody tonight, so you're pretty safe. So there is the positive part about Zoom. I work in the Western Sydney as a professor of nursing. My area is in aged and palliative care, and it actually includes dementia. I think one of the most important things is I like to think that I'm a champion for older people. And the majority of my students, PhD students, actually are doing projects in aged care. And I think that is really extremely important. There are a group of people that I believe that we cannot ever forget. So today what I'm going to do is I'm going to cover a broad perspective about older people, ending up with the barriers to consider when planning programs and what research have found in digital programs. I think it's important when we are doing older people that just to give you an insight of the demographics at this present time is really very important. As we all know, there is declining birth rates and increased life expectancies have resulted in a significant increase in the number and proportional older people in Australia. Between 2000 and 2030, the Bureau of Stats projected that Australia's population will increase by approximately 1/3 in the same period, the number of people aged 65 years and over. And it's actually going to increase approximately about 139%. So we're looking at approximately 5.7 million people, older people. And if you look at the trends in population in aging, in Australia's population, especially in the regional population, you would note that in those areas, it is actually increased greatly over the last 20 years. Aging was much more pronounced in regional areas. This was especially the case in Western Australia and places like that where the numbers have increased. Amazingly, what I found as I was searching, that there was not a lot about Queensland. And you know, as well as I know, that a lot of older people have actually moved across to Queensland. I mean, the climate is warmer and some of their lifestyle is so much better. And they are there because it's a more comfortable, a good place for retirement. And you also will note that there is also the trend in the population where there are lots more movement in the coastal regions. It's estimated a growth of 210% in the number of seniors between now and 2045. So it's good to actually look at the trends, because the trends would actually give you a really good idea of the sort of programs that you should be developing. Where is this population? Where should we be focusing? And therefore, here is the concentration. And therefore, this is the area that we should be developing a particular program for them. So also what I've felt that I needed to talk about today, which is terribly important, is about the misconceptions on aging and health. Unfortunately, you might talk to a lot of people and they would say, I respect the older person. My grandmother is an older person, my family. But when you start to talk to them and you see the things that they do, often there is misconceptions on aging and health. Some of the most important barriers to developing good public policy on aging are pervasive misconceptions and negative attitudes and assumptions about older people. Although there is substantial evidence about the many contributions that older people have made, unfortunately, people forget their contribution. Instead, they look at older people as frail, out of touch, and is a burden to society, burden to healthcare as well. So you have this negative attitude. People don't talk about it, they don't say about it, but it's their actions that actually speak for itself. There is one of the misconceptions, there's no typical older person. Older age is characterized by great diversity. Some 80-year-olds have levels of physical and mental capacity that compare favorably with 20-year-olds. Others of the same age may require extensive care and support for basic activities like dressing and eating. And because we are seeing a lot of more people in dementia, that's what we are also seeing as well, that they do need 24-hour care. And unfortunately, people just home into the ones that need a lot of care. So policy should be framed to improve the functional ability of the older person in all the various aspects of the older person, the ones that get function really well, the ones that are not able to function as well, the ones that can do some things for themselves but may not do a lot of it. And some, they're not able to do anything at all. So when you look at programs, your targets should be, okay, what am I targeting? And if I'm targeting these groups of people, what are the types of people within the elderly that I need to actually target in such a way so that they could understand and give a little bit more help. So that is very important. There is no typical older person. And the other thing is there's the diversity in older age is not, diversity in older age is supposed to be not random. A large proportion of the diversity in capacity and circumstances observed in older age is the result of accumulative impact of advantage and disadvantage across people's life. The physical and social environments in which we live are powerful influences of healthy aging. Yet the relationships we have with our environments are shaped by factors such as the family we were born into, our financial situation, our sex, our gender, our health, our genetics. So the diversity for older age is quite difficult for a lot of people to actually plan programs. Now, what sort of groups we should be targeting? How should we target these groups of people? Should we put them all together and then run our programs? Or should we be selective or to break down into different groups and organize different types of programs for various groups for what their needs are? So policy must avoid reinforcing health inequalities that underlie much of its diversity. So you just don't go in and run programs to only one group of people that can communicate with you so very well. You need to actually think about how you're going to help them in all the various groups and plan your program to suit their needs. And that is, to me, crucial. Only a small proportion of older people are care dependent. In fact, older people make many contributions to their families and societies. Research in the United Kingdom of Great Britain and Northern Ireland and areas like that, contributions of older people make through taxation and consumers, economic, is immense. So it's not just a small proportion. We see a small group of people because they can't confined to nursing homes and residential facilities, but they are all out there. If you went to a hospital today, to actually find someone in their 50s in a ward is considered young. Majority of people are actually over 60, and they are considered young. I must admit, as I get older, I look at these people, and even in their 70s and 80s and 90s, I now say in my head, they are young, right? So as we get older, we look at older people in a different way. When we are young, I just remember if my uncle was in his 25 or 30, in my mind, of course, not saying it to him, I really think he's pretty old. But as you get older, you see things differently. So policy should avoid stereotypical views that lead to discrimination against groups simply because of their age. The population aging will increase healthcare costs, but not by as much as expected. Now, everybody talks about, older people are going to cost us a lot more money. They're very expensive. But you'll be surprised, although older people is generally associated with an increased need for healthcare, the link with health service utilization is weak. For example, despite the high burden of disease in low-income settings, older people tend to use health service less often than younger adults. Do you believe this? It's amazing. They actually, considering they've got a lot more disease and comorbidity, they actually use healthcare less than younger people. In high-income countries, there's growing evidence that at around age 70, healthcare expenditure per person falls significantly. Because what happens is many of the older people, either they're taken care by their families, or they go to long care, long day care, or residential aged care to take care of them, where a lot of times is funded by their own retirement funds. So although we might think they're going to cost a lot more, it is not true at all. 70 is not yet the new 60. There is little evidence that older people today are experiencing life in better health than was the case for our parents or their grandparents. Now, what I thought was very interesting in an analysis done by WHO in 2014, which was a large longitudinal study conducted in high-income countries, suggested that although the prevalence of severe disability was there, it is not better now as you might think previously. So although you might think they've got more healthcare, there is more, people are living longer, but you also have to question the fact that it's not about living longer, it's about the quality of life. So is the quality of life much better? For many, it is not much better. So if you compare to the days of your parents or your great-grandparents, it's almost similar. So investing into healthy aging is crucial for countries to benefit from population aging. So healthy aging is really important. Good health in older age is not just the absence of disease, and that's what WHO would say too. Most people over the age of 70 experience a number of health conditions at the same time, but continue to be able to do the things that are important to them. So I could have a mild heart condition, but yet I could actually function unless it's gone really bad and may require surgery. I may have disability, but I could move reasonably well to go shopping. The only thing I might not be able to do is actually walk as fast as some other person. So the combination of a person's physical and mental capacity is a better predictor of their health and well-being than the presence or absence of disease. Services that are integrated and focus on improving older people's intrinsic capacity actually have better outcomes. Families are important, but alone cannot provide the care many older people need. While families will always play a central role in long-term care, changing demographic and social norms mean it is impossible for families alone to meet the needs of care dependent on older people. Long-term care is about more than meeting basic needs. It's about preserving the older person's rights, fundamental freedoms, and human dignity. I really think this is a really crucial area. One of the things that I don't see enough, and I'm sure you don't either, I walk into a residential facility and I never forget the day when my mother was there. She passed away in 2012. And she was totally immobile. And we all took turns to drive all the way to Kurumbong to spend the whole day with her, to feed her morning, lunchtime, and dinner, and then about 8 o'clock drive home. I remember one day it was my turn to rush from church. I left church at 11, And we drove all the way up there. And it was only 12:15, and the food, the tray, was taken away. I stood there and I was quite stunned, and I thought, oh boy, this is what a trip of rushing, and Mum has eaten. So I went up to the nurse and I said, Mum, her tray is not here. Is there a reason? And they said, your mother didn't really want to eat very much. So I said, okay, do you mind bringing the tray back for me? And they said, yes, all right. So they brought the tray, and because I had the time, I sat there and I fed her. And she ate everything. And when they came back, they saw the food. The two nurses came back, they saw all the food was eaten, and they felt really bad. And they said to me, we're so sorry. We got 16 residential clients we had to feed, and we can only give them 15 minutes of time for each one. So if they're not able to eat, the tray is taken away. All right. So I said to them, haven't you thought about volunteers to help out in this? Unless a person can't really eat and got swallowing difficulty and should be taken care by a trained nurse, but the community can help with feeding somebody. So I said, why aren't you using all these people who live around here to help with that during feeding time? We could take turns, I do a Tuesday, somebody would do a Wednesday, whatever. So it's not just about government helping. Volunteers could also be encouraged to do community for the older person. And unfortunately, that is actually forgotten. That you got the expenditure on older population is an investment, not a cost. Well, healthy aging starts at birth with our genetic inheritance. Only approximately 25% of the diversity in longevity is explained by genetic factors. The other 75% is largely the result of cumulative impact of our interactions with our physical and social environments, which shape behaviors and exposures across the course. So you couldn't sit there and say, it's because of my genetic that I've got a heart condition. Maybe so. But if you take precautions and you lead a healthy lifestyle and you take charge of it, you may not be the candidate that may require surgery, and you may not be the candidate that will end up not able to function if your lifestyle is actually looked at carefully, and your physical care and your nutrition and all those different things that make up your health and well-being would actually change things for you. So expenditure on older population is not an investment, not a cost. Policies should address this person-environment interactions. I have to say the very sad story here is the government puts a lot of money into acute care. They fix the problem. But not the underlying root. So prevention, unfortunately, doesn't seem to be the investment of the government. If they had used more on running programs with health promotion programs, healthy programs, and all those programs, and teach people, I don't think we have as many sick people. Who wants to be sick? I mean, you can have all the money in the world, but if you don't have health, it has no meaning. That's what it comes down to. So the bottom line is nobody wants to get sick, but I think people need to be taught or shown how to live a healthy life. And that's where you people play a tremendous role in what you are learning at this present time. That's how I see it. Then there is also the misconceptions on aging and health. Rather than framing the expenditure on older people simply as a cost, they are better considered as an investment. These investments can yield significant dividends, both in the health and well-being of older people and for society as a whole, through increased participation, consumption, and social cohesion. Policies should be framed in ways that enhance the abilities of older people. And all these people that you have to retire at 60 or 65. Who said so? A person who's 60 and 65 is young. They're not old at all. If they kept healthy, can be such great asset to the country. And I remember in Hong Kong, people who work in academia in Hong Kong are the best earners in the world. They earn a lot if you're an academic. But unfortunately, they can only work to 60. At 60, regardless if they are healthy, they are asked to retire. Who said so? Why do we do these sort of things to people? And people would say policies enforcing this will help to create jobs for the youth, but they reduce older workers' ability to contribute. They also reduce an organization's opportunity to benefit from the capabilities of older workers. Age has not been shown to be a reliable indicator for judging a worker's potential productivity or employability. And I don't understand that. I hope you will bear that in mind. In my mind, this is discrimination practices that we have adopted. And it should not be that way. So if people can experience these extra years of life in good health, and if they can live in a supportive environment, their ability to do things they value, and they can contribute, and they can share their wisdom with younger people. If they are given these opportunities, these added years are dominated by declines in physical and mental capacity. If you don't give people things to do, and they feel they are actually useless, it really affects their health and well-being. And it really has implications for older people and for society. And it's really very negative. You know, I think if you can work for many years and you are really fruitful, you've given a lot. And then when you reach a certain time, people say, you are no value to us anymore. Where is all that experience that the older person had, that a young person doesn't have? Why couldn't they share and work together and learn from each other so that they will be able to learn the responsibility of someone who is employed? Common conditions in older people include health conditions that we see are hearing loss, cataracts, reflective errors, back, neck problems, pulmonary obstructive airway disease, diabetes, depression, dementia. These are common geriatric syndromes. Furthermore, as people age, they're more likely to experience several conditions at the same time. But that can be prolonged. Like if you are prone in getting dementia and you've got a genetic history of that, let me say this to you, that can be prolonged if you know what to do. So you might end up getting, but you might not get it so early. May I say to you, everyone who gets dementia actually knows they're having dementia. They are covered by their families. Oh, she forgets it very often. Oh, my wife, Florence just forgets it. She doesn't remember this. So your family makes excuses for your forgetfulness. But the day will come when they don't even know where they live. But they know they're getting dementia. Most people do. Environments also have an important influence on the development and maintenance of healthy behaviors, maintaining healthy balance, engaging in regular. So this is healthy aging, about maintaining healthy behaviors. This is what you are aware of. The balanced diet, engaging in regular physical activities, refraining from tobacco, alcohol, risks of non-communicable diseases, improving physical and mental capacity. All the things that lifestyle medicine is actually trying to push it along for the people out there. There's no difference for older people. Behaviors also remain important in older people. Strengthening, maintaining muscle mass, good nutrition, preserving cognitive function, supportive environments enable people to do what is important to them and provides a very safe environment for them to move around and to walk around. One of the things I noted when I was in Hong Kong, because I spent a lot of times with students there, because our university was connected to their other universities, and what really troubled me a lot, the railway station, had no way of access for older people. Older people are just kept in their homes with no transportation or cheaper transportation for them. There is no access to even get onto the train fare. And I am actually very disappointed with the British, who lived there for 100 years and actually did nothing in regard to that area. So people are kept in their homes. If you are older, too bad, unless you are well off and can afford taxis. So the health inequalities are crucial. Public health policies must be crafted to reduce rather than reinforce these inequalities. There is a rapid changing world. Older people are often assumed to be frail or dependent and a burden to society. Public health and society need to address this and other aging attitudes which can lead to discrimination and actually affect policies for healthy aging. Whose response is to develop in such a way it has all these areas that we need to actually include. They have got a strategy and action plan that draws evidence of World Report on Aging and Health, and there are 5 priority areas for action. One is commitment. They want countries to be committed to healthy aging, align health systems with the needs of older population, developing systems for providing long-term care, creating age-friendly environments, improving measurement, monitoring, and understanding. These are the 5 priorities that all countries need to abide by. Now, I need to mention that we are in a situation now where we have got COVID. It'll be a while before we can really travel overseas. We are really in our country might be fine, but other countries are not. So we are stuck. So we mustn't forget, if we forget what we are doing about social distancing and all that, and we think we are okay, we're fine, and we go back to our old ways and forget that there are people that can bring in COVID to the country, may I say to you, we could end up like a second India. So the way we run our programs has changed drastically. So severe illnesses means the person will be hospitalized, intensive care, on ventilators, and they may even die. And I think that is quite a scary thing. This is the part I like to talk about, the barriers to older adults' uptake of mobile. I'm going to take another 5 minutes, Paul, because we encroach into my 40 minutes. So, teasing you. Barriers to older adults' uptake.
No problems.
Yes. Barriers to older adults' uptake of mobile, digital, and internet. You actually have to move along this kind of pathway, but there are technical challenges accessing and engaging, and there are some negative psychological effects. There are technical support throughout the engagement. When you are running your programs and you are dealing with older people, there must be continual engagement. You have to do your demonstrations slower. You have to take time in your interventions with them. You cannot rush through, and you have to monitor them, and you must keep monitoring them throughout your programs. If you don't do this, your programs will not be successful. Older people will actually give up quite easily. This is too troublesome. I can't continue with this. And picking up skills sometimes are not as quick for some of them. And older people also rely on trusted facilitators. You have to get them on site. You have to build trust on them. There needs to be privacy and confidentiality. You need to address these issues because of all the media exposure to negative things and all that. There is actually a lot of negative thoughts. So when you run the programs, you got to actually gain their trust. Older people need frequent reassurance. Failure to address these issues will cripple your interventions or programs, especially with older adults that have lower health literacy or mental issues. Research has also shown that older adults are very cautious. And also something that I think you are aware, depression is a common significant problem among older people. Majority of people don't even know they've got depression, and also do not seek help if they do. Behavioral prompts or nudges may be required for older users to maintain high motivation and to ensure continued use of an intervention. Trust is really important. Health promotions, their GPs, these health professionals should jointly help you with the running of the programs. And when you get trusted people, health professionals and trusted people involved with your program, you actually give confidence to the older people when you're running these programs. So moderate physical activities, research have found, increases immune response. Building capacity for inclusive online recreation services. Finding innovative ways to maintain social contacts and ties. Your programs will actually help to do this. Social digital leisure can be one way to combat this isolation. Professionals can direct older people to existing online opportunities, including nutrition, cooking, games, different things to make it interesting. As mentioned to you, depression is also common and a significant problem among older people. This needs to be considered when developing interventions. In conclusion, environments have an important influence on the development and maintenance of healthy behaviors. Public health and society need to address these and other ageist attitudes which lead to discrimination, which affect the way we offer policies. Our own attitude also play a part on how our programs are run. When running programs, older people require high level of support throughout the program for its success. Thank you. I have to say I'm very hot, so I'm taking my jacket off. I'm ready for any questions.
Thank you very, very much, Esther. Who would like to go ahead with the question? Esther, go ahead.
The question I was going to ask the group, are you comfortable in running programs for the older person? Does this help you to give you an insight to older people when you run it?
I think Louise there has raised her hand. Just go ahead and unmute yourself, Louise, and you can ask the question.
I can't see the raise of hands, so.
Yeah. Yes, I'm comfortable, is what I was saying.
Oh, nice.
That's good. Yes. And also it depends on your age group too. As you get older, you have a little bit more understanding. As you are younger, it's nice to know these things because older people can be very stubborn as well. You know, if they have their mind set about certain things, sometimes it's hard for them to change. But if they trust you, you're more likely to do that. I was talking to Paul, and I was talking about CHIP, for example, one program that you all will get involved with or run it. I feel sometimes when we share these plant-based, we might tend to push our agenda by saying plant-based is really very good, and this is the way you should be doing it. And if ever the word vegan was brought up by mistake, that is really quite a bad word for many people. So I really think it's actually important to give people options, to actually show them a contingent area of how it is, where they would like to see themselves. If they are on this side, you can see you would do better, the outcomes would be better, your diabetes would be better, your health as a whole would be better. If you are on this side, the middle side, you may get improvement, but maybe not as well as on this side. But the choice is actually yours, where you would like to see yourself. Give people the choice to make those decisions, because when you do that in your programs, they will own the problem.
Yeah, thank you, Esther. Lyle Heiss has made the comment, I might be the oldest in the group at 73 plus. I want Esther as my primary nursing carer. So I think Lyle's probably suggesting that in about 30 years, when he needs nursing care, he'd like you to be the nurse.
Yes, I started to realize this for myself when I was actually nursing hands-on in Hornsby Hospital. I mentioned the name. And I was doing clinical, even though I was working at University of Technology at that time. I wanted to make sure that my clinical skills was up to date. So I was working, and I was very disturbed with a story which I share with you. And I know it's being taped, but it's good to know it. There was this man that was actually dying of liver disease. And I just never forgot his relatives coming to me and saying, he wants to eat a peach. And I said, well, get it for him then. Oh, no, we can't do it. The doctors told us we can't. So I said, why not? So I thought, I'm going to challenge this one. So I went, and when his consultant came in, I talked to the family and him about the man wanting to have a peach. He has no appetite. Personally, he doesn't have long to live, in my opinion. And he just wants that. And then there was all these stories about, if he took the peach, it would put him backwards and his condition would be worse and all that. And I was so disturbed. I thought to myself, he's dying.
Yeah, what
are we doing?
Yeah.
And so the relatives then approached me and they were very upset. And I know that I stood there and I said, go to the kiosk and buy him the peach. If that's what he wants, give it to him. And I left it there. And that made me realize I really need to go to aged care. All these crazy things were happening at that time. And getting people out of their beds and sitting there for about 6 hours and then asking them to eat lunch after that. What is this? And the patients would say, nurse, put me to bed. And they say, oh no, Mrs. Jones, it's so good for you to sit there longer. It does you a lot of good. And it troubled my mind. And I changed my whole nursing in acute care in ICU, and I was actually coordinating ICU, cardiac thoracic, nephrology, and all that, right across to aged care, because I realized there was a problem. So it's people's attitude to the older person that is quite scary. And that's why this commission that's taking place of the older person at this present time is very timely, because we need to change how we treat the elderly.
Esther, my wife works at a public hospital not far from where we live, in the rehabilitation ward. And one of the things that she finds very frustrating is that the older patients come in, they basically stir up their medication, send them home again, knowing that they're going to be back in 3 or 4 months.
Yes.
And it's just this sort of revolving, instead of dealing with the underlying issue, which you mentioned beforehand.
Yes.
They're just trying to treat the acute problem. And the big issue seems to be they just don't seem to have the time.
Mm-hmm. That's totally correct. So they're missing the point about treat the acute and forget heart prevention, and to teach them and teach their families.
Yeah. And how do we, I mean, obviously, if you give the patient more time, it's going to cost a lot more money. Is that a realistic thing to expect, or is that just the system we've got to live with?
I think we have to actually come to the point of looking at the sort of things that people are doing for the older person. Some of the jobs do not really require a registered nurse.
Yes.
Which would cost them a lot more money. But to be able to teach them and send them for training and how to manage older people, someone from the community, when they are being trained, and of course you track them to see that there has not been any physical, as you know, to work in aged care now, you got to actually check to see if you are allowed to work with your criminal records and everything. You have to look at those things and then train people that it would not cost them that much. As a matter of fact, the government is now been having older people at home because they actually realize it's actually much cheaper to have them at home than to actually have them even in long residential aged care facilities.
Yeah.
Esther, if I could ask a question, and I love, one thing that I greatly appreciate and admire about you is that, you have this real heart and the story you've just told there about, you felt that, hey, things need to change and you're the kind of person that gets there and make change happens, which is just a beautiful thing. But I'm interested, you alluded to this idea that, there are developing trust is really important, and there are certain skills, maybe presenting things, perhaps a little slower. It's interesting. I come from an education background, and I was secondary teaching and then university most of my life. And my wife's a primary teacher, and I remember I had to teach a lesson to younger kids. These are lower primary school. Yes. And I went in there, and within like 1 minute, I'd lost them. And I just realised I didn't have. Obviously, I don't have the skill set to be able to really engage. And my wife would walk in there, and all of a sudden there would just be. It was running smoothly, and I just thought, wow, there's a unique skill set required to speak and communicate and connect with that demographic. And actually, look, I think, confession time for me, I think the aged care sector is a group that I actually haven't had a lot of experience with. And I think I would find that challenging. And I'm fascinated to know from you, what are the unique, because I've seen people do it so well. I've been into aged care facilities where there are certain nurses or carers that just have this unique ability, and it's just completely admirable. What is it? What is that? Those unique skill sets that they bring that allows them to connect in that way?
I think it's the issue of getting to know them as a person. You will find out when you chat with them, they tend to repeat a lot of their stories to you because their long-term memory is really very good. It's their short-term memory that's not as good. So they would keep telling you stories, and they would tell you different things, and you would come back to them and say, I remember what you told me yesterday, and you said you needed something, and you like this particular drink, or you like this whatever. I have brought it for you to try today and see how you like it. So what you try to do is gain their confidence that you're someone that they can rely on, and taking time to chat with them. Chatting with them is really important because you then get to know them, know what their idiosyncrasies are, what they like, what they don't like, what they're scared, what they are. So you actually get to know who they are, and then you start having conversations, and they notice that you have an interest for them. And because you've got an interest for them, sometimes they say, "You're such a good boy. You seem to, or you're such a good girl. You always think about us. You're so kind," because you have formed a relationship with them. And I think that with the older person, that's how you have to deal with sometimes, because there's too much on the media about how many people cheat older people and do all these scamping stuff and all these different things that they do. In a sense that there is always the fear that people will do harm to them. And you got to gain this trust.
Esther, Marit has raised a question. You commented there that it actually costs less in medical costs for the elderly than it does for those in the younger generation. He was interested in that. Could you just expand on that a little bit more?
You yes, mentioned in your presentation. What the research has shown, that I could for many years have thought that younger people cost less and everything.
Yeah, that was my assumption too.
And older people are more expensive. But it's not true, because younger people, you see that there are lots more people. If you go in, you see a lot of young people coming in for all sorts of injuries and all sorts of sports injuries and all different things. And with the older person, just remember, they do need a lot of care. The ones who need care 24/7, when they do go into long-term care, a lot of times their pension and all those different things help to pay for those expenses.
Right.
So once they reach about 70 and age of that nature, their expenses are paid by whatever they've got that helps to pay. And so their savings come into it. And sometimes their housing comes into it as well to pay for those things. But younger people, when they come in, that's not taken. So although they might think that, they are cheaper, and they don't come and see the doctors so often, look at all the little kids that keep coming with their little flus and sickness and illnesses that they pop in all the time to see because they're down. And now if you are sick with a little cold, you can't come to school until you go and see the doctor and do a COVID before you can come to the school. Look at how much more expensive things have been.
Yeah, okay. Yeah. And so what you're saying is that the older people actually fund a lot more of their own costs.
Yes, it is definitely more expensive if you say total functional needs. But once they go into long day care, honestly, it's covered from a different budget.
Yep. Okay. Yep.
Okay, so they're not actually costing more money.
It's not coming out of the tax dollar.
No, it's their own money, actually.
Yep.
Majority, I'll say. Of course, there are a few that still require, but they would be on some form of pension.
Yep. Excellent. Thank you very much. Well, it's 8 o'clock. And Esther, I'm really impressed. Your voice has lasted exceptionally well with only coughing a couple of times. Thank you so much for taking the time to make this presentation for us and just expanding our thoughts and our thinking in this population that we often don't spend a lot of time thinking about. So once again, thanks very much for your presentation.
And thanks for inviting me, Paul and Darren. Really appreciate it. Darren and Paul has always been my friends.
Yes.
For many years.
For many years. We've had a lot of fun together.
And Darren has done research with me. We've always had joys when we were not successful as well, Darren.
Yes.
Yes.
So true.
Yes. And I want to say something which I always admired about Darren. He was a team player.
Absolutely.
Mm-hmm. So thank you. Thank you. I wish you all the best, everyone. And I'm sure this is a good cause to undertake. And what you're doing would actually, I believe, will help to focus on lifestyle medicine and how people need to change their lifestyle to remain healthy.
Thank you very much.
Thank you, Esther.
Okay. Bye.
Bye.